Hi, everyone. Welcome to the December Washington Healthcare Facilities Community of Practice webinar. My name is Ryan Kronk, and I'm with the Water Institute at UNC, and we serve as the Secretariat of the Community of Practice, and we have an exciting presentation today, so I don't want to delay, but we do have a few quick announcements. We do have three.
But I think he's glad that this is.
We do have, three upcoming sessions. We have the WHO will be giving another presentation in January on the upcoming wash fit evaluation. We have Josh Miller and the WISE team presenting on the measuring wash experiences in healthcare facilities in the NWISE scale. That'll be the wash fit evaluation will be on the 22nd of January. The NWISE presentation will be on February 6th, and then our own Darcy Anderson will be presenting on two systematic reviews that we've done on WashFit, on their impacts and adaptations, along with a panel discussion with USAID, and that will be on February 26th. So we have a really busy and exciting upcoming schedule. With that, we'll just pivot to today's agenda. We just have one presentation today. Dr. Rick Johnson from the WHO-UNICEF Joint Monitoring Program for Water Supply, Sanitation, and Hygiene will be presenting the latest JMP data on Washington healthcare facilities, the 2023 data that was just published, I believe, in October. If you'd like to read the report, please go look at the email that we sent around for this session, and you can grab the link and download it, or go to the washdata.org to download the latest report. Rick is interested in questions, so if you have questions along the way, please drop them in the chat, and we'll do a Q&A at the end of the webinar. So I will stop sharing and turn it over to Rick. Take it away, Rick.
Thanks, Ryan. So I'm Rick Johnson from World Health Organization, and I was sharing my screen before, and I'm not sure if you can bring it up again or if I need to take some action.
You're good, Rick. It's live.
We see it. Yep.
It is. Okay, perfect. Yeah, so happy to join the webinar today on behalf of both the WHO and UNICEF sides of the Joint Monitoring Program. And we have now published 4 global updates on Washington healthcare facilities since a baseline in 2019. And now we're on a 2-year reporting cycle. If we could go to so let's see. You're seeing the second slide now? Because I can't see what's on the screen. Can someone just confirm that you're seeing the second slide?
We are. We're seeing the JMP 2024 report slide number 2. Yep.
Okay, perfect.
Yes, I
yeah,
can
my
see.
different monitors are showing different things. Perfect. So this report that just came out this year, a couple months ago, then updates and supersedes the data from our previous report in 2022. We're calling it a data update. Well, a 2023 data update because it includes data through 2023. And we use the term data update to indicate a shorter report that just focuses on the basic WASH indicators at the national scale. In comparison, a full progress report would go into more detail about inequalities and highlight examples of monitoring that go beyond the basic indicators. Like our 2022 report, it was a full report, and you can see it was significantly longer. And we do this because we produce the reports on Washington schools and Washington healthcare facilities in the same year, and it just reduces a little bit of the burden of producing 2 full reports. So this report included data from almost 700 data sources, which could be healthcare facility assessments or surveys. It could be MIS systems or other types of published reports. And together, they represent at least 1.2 million healthcare facilities, which is more than twice that from the 2019 baseline. In the report, we cover 5 service areas, water, sanitation, hygiene, also waste management and environmental cleaning. And for each of them, we've defined 3 service levels: the basic service, limited services, and no service. All of those
You are muted, Rick.
Sorry, Rick. We accidentally got muted. Go ahead.
Sorry about that. Okay. I was saying that the basic service levels are all composite indicators, but they are still very basic and don't cover a lot of important aspects of WASH services, for instance, water quality or hand hygiene compliance. So those higher levels of service, they're quite data poor at the global scale, but we do highlight good examples of those in full progress reports, but not in this shorter data update. For each of those service areas, we've recommended a set of core questions in this document, which was first published in 2018. And those could be included in facility assessments or in routine MIS systems to collect all of the information needed for those 5 service levels. And there are 16 recommended questions in all, ranging from just 2 for hygiene or environmental cleaning to 6 for sanitation. So this report that came out a couple months ago then had a special focus on WASH and primary health care, or PHC. And what we wanted to do with this was to explore the different linkages between WASH and PHC and articulate why WASH is important for PHC and also PHC is important for WASH. We wanted to direct our audiences who are more coming from the WASH world towards some of the frameworks, concepts, and resources available in the PHC sector. And I especially want to focus on that diagram on the right, a circle, which is the fundamental framework of the 3 core components of PHC. The first is primary care and essential public health functions, that's in yellow. The second is addressing the broader determinants of health through multisectoral policy and action, that's in blue. And the third is empowering individuals, families, and communities to take charge of their own health, and that's shown in red. So often that red bit, the yellow bit is where people put their focus. It's about primary care. This is the part that takes place in the healthcare settings. But really adopting the PHC approach means to be working intersectorally, including at the community and individual levels. And I think it helps when a WASH sector practitioner engages with the healthcare sector to be able to speak a little bit of their language and to say, for example, that yes, WASH is essential to advancing PHC, but also to flip it and say that adopting a PHC approach is critical to improving WASH services, whether that's in healthcare facilities or more broadly. So we wanted to highlight similarities between the PHC and WASH worlds in terms of frameworks. PHC has what they call 4 core strategic levers, and the report shows that all of these have WASH corollaries, especially in the SDG 6 Global Acceleration Framework and in the sanitation and waterfall building blocks and collaborative behaviors. These are nothing radical, governance, funding, political commitments. PHC also refers to 10 operational levers for PHC. And in the report, we show how each of them has some degree of linkage with WASH. Most obviously in physical infrastructure, and that's where the health sector tends to situate WASH in healthcare facilities. But we argue that all of these actually have some linkage with WASH. For instance, models of care rely on patients and caregivers having access to safe WASH in healthcare facilities. And for the primary healthcare workforce, WASH is crucial to enable them to deliver quality care, both in healthcare facilities and in communities. Finally, PHC does have a small set of 13 core indicators that are important for national, regional, and global monitoring. And that includes a WASH indicator, WASH amenities. And by amenities, that also includes environmental cleaning and healthcare waste management. Okay, so if we turn to the data that we've published in this report, I mentioned that we drew on almost 700 sources. It's actually 692. And here you can see the distribution by those different service areas. There are relatively few for environmental cleaning, only about 100, but they're growing fast. And the different shades within a bar indicate what type of source it is. And we're drawing mainly on facility assessments and surveys, but we're definitely seeing strong growth in the availability of administrative data, such as HMIS. And then if we turn to the number of facilities represented, I mentioned we're covering now over 1.2 million healthcare facilities, and that's steadily increased over the different report cycles. Actually, in this report, we used a new data series for rural Indian health services that's got about 15 years of data with almost 200,000 healthcare facilities per year. So we excluded that from this graph because that would have added another 3 million to the 2024 figures, which isn't, really comparable. Then we can turn from the number of sources and healthcare facilities assessed to the numbers of countries and the proportion of the global population represented. We see the number of countries in bars steadily increasing. The different colors of the bars are the income groups. So the darker ones are the low and middle income countries. Steady increase there. But the circles and the lines, they show the proportion of the global population. And you can see that between the 2022 and 2024 reports, we had a big drop in water and hygiene. And that's because of aging data from one big country, from China, where there was a nice 2018 survey that hasn't been repeated yet. And now that's too old for us to use for 2023 estimates. And that's a shame because the JMP won't make regional or global estimates unless we have actual data from countries representing at least 30% of that population. So that means that we are now unable to produce global estimates for basic water or basic hygiene in this report. You can see that in this graph from the report where we show the data from 2022 and 2023, where in 2022, we could still use that 2018 China data source, but we lost it for 2023. One way we tried to make up for that in this report was to shift the focus from global to other groups of countries that had more data in them. And in particular, OECD defines a set of 60 fragile contexts that could be politically or economically fragile. And there ends up being a lot more data from those countries, but also people living in those countries are more vulnerable, have greater needs for wash services in the healthcare facilities. So you can see that we were able to get all 5 of the service ladders for the set of fragile contexts. And as in many countries, we tend to see higher coverage for water and hygiene and lower coverage for environmental cleaning and waste management, and frequently basic sanitation being the lowest of the 5 basic wash indicators. I wanted to orient people a little bit to the JMP website as well, washdata.org, in case you haven't explored it. It does include an interactive data portal where you can explore the database and create your own figures or tables or maps. Here you can see one of the default charts in the upper left that shows the basic wash ladders for 2022 and 2023, just like I showed a few slides ago. And you can also see in this map on the right that Uganda is one of the countries that has estimates for all 5 wash indicators, with sanitation being the lowest. This year, in our report, we had 29 countries with all 5 ladders, nearly double, up from 16 in the 2022 report. Also on the website, you can download Excel files, we call them country files, which include all of the data sources used, as well as the resulting estimates. And if you're mainly interested in an individual country, or if you want to understand, well, where these estimates come from, this is the place you should go. You can also download the files for households and schools from the same page. And here's an example of the Cambodia country file. Each of the country files has a number of different tabs, about 10 or so. So I'm just going to show you a few of them here. This is the introduction tab. One thing this allows you to do is to select different languages. So I'm showing it in French here. Right now it's available for the UN languages, but if you really wanted to translate the glossary of about 200 phrases used in the file, you could insert that in the file and convert it into whatever language you like. This is the data summary tab. I'm going back into English here. And here you can see that for Cambodia, there were 6 data sources that we used to produce estimates. Each data source is a row, and then each variable is a column, and you can see what variables we could extract from each data source. The most recent data source here is a 2024 health facility survey, which was very well aligned with the global indicators. So you can see that there are lots of numbers in there for the different sanitation indicators, whereas some of the earlier surveys, like the 3 EMONC, emergency maternal and neonatal care surveys, they had some information about sanitation, but pretty limited, just whether the healthcare facility had improved sanitation or maybe improved and usable sanitation. Also, a lot of those earlier data sources didn't disaggregate by urban and rural. So this new data source is really great and filled a lot of data gaps. Another interesting tab is in the country file is the charts tab, where you can see how those different data points were used over time and the resulting linear regression estimates. So in the kind of upper right hand, you can see for water in hospitals, there's a very strong positive trend for that thick dotted line, which represents improved water on premises in Cambodia, coming from the 3 EMOC surveys. And you can also see that for urban and rural, we only have that one recent data point, so we can't say anything about the historical trends. So yeah, the country files have a lot of detail in them if you're interested in, a very detailed look at the statistics. Let's go back to the big picture though and turn to water and the regional and global statistics. So the definition of a basic water service, it's a composite. It's about having water that's available from an improved source that's located on premises. So there's 3 factors there. And in this report, we had enough data from 2 of the SDG regions, Sub-Saharan Africa and Northern Africa and Western Asia, as well as 4 of these other groupings, like least developed countries, the fragile context I mentioned before, landlocked developing countries, and also small island developing states. And you can see a range from 60, 76% of those healthcare facilities having basic water services. Now, more countries have data on improved water. Remember those EMOC surveys from Cambodia, but you can have improved water that doesn't meet the basic requirements. So that improved water source might not be located on premises, or water might not actually be available. If you think of piped water with intermittent supplies, it's improved, it's on premises, but water is not actually there when you make an assessment. So everything to the right of that diagonal line then has improved water, but not basic. We could look, for instance, at Sudan, where about 80% of healthcare facilities have improved water, but basic is only at about 20%, a little bit higher. And that means that some of those improved supplies are either not on premises or that water isn't actually available. And in the case of Sudan, the challenge is more to have water available on premises, whereas in Kyrgyzstan, the limiting factor is more about having water that's actually available from the improved source that is located on premises. This is an example of one of the charts you can make on the website. It's called a rank chart, and it shows improved water on premises in non-hospitals, so smaller healthcare facilities. And this one is restricted to those fragile contexts. There are 60 of those, and in 26 of those countries, they have data on this indicator, which ranges from 100% in a couple countries, in Iraq actually, down to just 17% in the DRC. And here you can see that in Sudan, only 31% of the non-hospitals have improved water on premises. So on premises, again, is the limiting factor here. Also on the website, you can save dashboards and get this URL. So if anyone types in that URL, you will get this exact figure, and then you could continue to edit it and adapt it to make your own figure. Now, the basic sanitation indicator, this is the most complicated of the indicators. It's got all of these elements about having improved sanitation facilities that are usable, but also meeting the needs of different groups within a healthcare facility. So staff, sex-separated toilets with menstrual hygiene facilities, accessible for people with limited mobility. And that does tend to lead to lower coverage for this indicator. We still have those 2 SDG regions and a few of those other regional groupings, but here you're seeing coverage is more like 20, maybe 30%, whereas for water it was 60, 70%. And that's because of these multiple sub-indicators. So this heat map chart shows all of the different elements of not safely managed, of basic sanitation. And you can see that a lot of healthcare facilities will have a lot of sanitation or improved sanitation. It's 100%, it's 95%. But as you move to the right, some of these other factors become limiting. So if you look at the very bottom, you see Somalia, where 96% improved sanitation facilities, but only 21% of those have menstrual hygiene management or accessible to people with limited mobility. You can see also some gray bars because some countries have not all of the indicators available. And the JMP will make estimates if we do have data on improved and usable sanitation and at least 2 of the other 4. So that's staff, sex-separated, menstrual hygiene, and limited mobility. And because those different sub-indicators might come from different data sources, we can't always combine them at the level of the health facility. So we just take the minimum of all of those at the national level, or if we're talking about hospitals or rural, whatever, we just take the minimum of those sub-indicators. So if you look, for instance, at Burundi, kind of in the middle, you can see it doesn't have data on menstrual hygiene or limited mobility, but only 48% of healthcare facilities had sex-separated toilets. So that ends up becoming the basic sanitation statistic. Now, if Burundi did have data on menstrual hygiene or limited mobility, that number would probably be smaller. This is just the bottom half of that table where you can see, especially menstrual hygiene and limited mobility can be quite low in a number of these lower and middle income countries. The dots by the name of the country indicate their income status, and the other icon indicates if it's a fragile context or not. So you see quite a lot of fragile countries having these very low levels of basic services. Okay, on the website, you can also make tables. Here's an example showing countries in sub-Saharan Africa that have data for urban or rural on menstrual hygiene or limited mobility in sanitation facilities. And you can see in Somalia, higher coverage in urban than in rural, 12, 20, 25%, both for limited mobility and menstrual hygiene. So these tables can be a nice way to download the data that you're interested in, because you can choose which indicators and which countries you want to collect data on. Let's turn to hygiene. Hygiene is a simpler indicator. It's got 2 elements about having functional hand hygiene facilities, both at points of care, which could include alcohol-based hand rub, and at or near toilets, which really has to be water and soap. And again, we have the same 2 SDG regions that have relatively higher data coverage and also fragile contexts, with just less than half of healthcare facilities in fragile contexts having these basic hygiene services. Now, between those 2 factors, they're the sub-indicators. Usually the limiting factor is having water and soap at toilets. So the points that are to the right of this line here, they have hand hygiene at points of care, but they don't have it at toilets. And often countries don't have data about water and soap at toilets because it's not been typically connected in standard healthcare databases. The report also lists the 20 countries that have at least 5% of the population using healthcare facilities that have no hygiene service, so neither hand washing at points of care nor at toilets, ranging from 7% in Nepal up to 68% in Sudan. On the website, this is another kind of chart you can make. This one's called a ladder chart, where here we're showing the World Bank income groups. And in the low income and lower middle income countries, there's enough data to make full ladders with kind of the progression you expect. But in upper middle and high income countries, there aren't enough countries that have data to make estimates. Let's look at environmental cleaning. Here, it's another relatively simple definition where there are 2 sub-elements. It's about having protocols for cleaning that are available and also about having staff with cleaning responsibilities that have all received training. Here we have only 11% of the countries or the population in sub-Saharan Africa. So we only have one SDG region that has enough data here. In Northern Africa and Western Asia, there were 12 countries that had data on this that represent nearly half of the regional population, but only about a quarter of those healthcare facilities met these two requirements. Because there are these two requirements, sometimes one is higher, sometimes the other. If we look at Bhutan, more than 40% of healthcare facilities have trained all staff on cleaning, but only about 20% of healthcare facilities have written protocols available. Whereas in Iraq, it's the other way around. Almost 60% of healthcare facilities have a protocol in place, but a little bit more than 20% have staff that have been trained. And I wanted to unpack this one a little bit and give an example of the types of national data sources that we draw upon for these estimates. So in the country file, there's a data tab for environmental cleaning where you can see this specific data source and the statistics that we've extracted from it. So you can see, one, that this was a very rich data source. It's got good disaggregation for urban and rural, for everything except for non-government facilities. And you can see here that we've extracted 57%, 56.8% of facilities had cleaning protocols available, but only 25% reported having all healthcare providers trained. From that report, you could also calculate that 19.8% of facilities met both standards. But again, because often we don't have these coming from the same data source, for the JMP, we just take the minimum of those two, which would be 25% at the total level, 51% for hospitals, 21% for non-hospitals. So, but where did these data actually come from? Well, they came from this survey. We call it a census because it covered all of the healthcare facilities, but it was really a WASH IPC focused assessment that was conducted by the Ministry of Health with support from WHO and UNICEF. And it's really detailed. It has 73 indicators. In most cases, they have 3 response levels, which are basically yes, fully, no, fully, and kind of partial in between. You can see here in red the different types of healthcare facilities. So it's nice to see kind of a range of coverage by the larger to the smaller facilities. For the global JMP reports, we just take hospitals as that first one, and everything else we would group together as non-hospitals, but you can see there are big differences even within those. And then for indicator 30, it reads, a procedure has been established for the cleaning of each room / setting regularly and when needed. So that's pretty close to the global indicator of protocols for cleaning are available. So in this case, we've taken yes, or the procedure is known but not applied as meeting the global indicator, because the global indicator just says, is there a protocol available? So even if it's not applied, it's available. So if you add 30% and 18%, you get that 57% you saw on the last slide. Whereas 31, this one matches pretty closely. The global indicator of all staff with cleaning responsibilities have received training, but there, because the global indicator is about all staff actually receiving training, we only took the yes responses, so about 25%. So that's how we move from a national data source to the global indicators and estimates. Let's turn to the last service area, waste management. Again, there's 2 sub-indicators here about having waste being safely disaggregated, segregated into at least 3 bins, and having sharps and infectious wastes that are treated and disposed of safely. We have the same 2 SDG regions, and coverage here again is lower, 26, 40% or so. We're getting close in some of the other regions. Central and Southern Asia had 28% of the population covered. It's just below our threshold of 30%. So hopefully in our next report, we'll be able to cross that. And maybe we're even close at the global level. This is another type of chart you can make on the website. This is a rank chart, but this time showing the full ladders. And you can see here we've restricted to the 46 least developed countries. And about, I think it's a bit more than half of them have data on the waste management indicators. The ones in gray don't. And you also see a lot of yellow, which is the limited service. And what that means is that there's some level of segregation or treatment, but not meeting the basic service levels. In Nepal, which is towards the right here, you can see that the limited category is quite big. It's at 13% basic, but 76% limited. That shows up also on this scatter plot. We're looking at the limiting factors because in Nepal, almost all facilities reported safe segregation, but only 17% reported safe treatment. And in contrast, the Democratic Republic of the Congo, half of healthcare facilities reported safe treatment and disposal, but almost none of them reported safe segregation. So of course, it's inefficient to treat waste that hasn't been segregated because you end up treating a lot of things that aren't hazardous. And it's also not a best practice to treat waste that has been segregated in a way that's not meeting basic standards. And that's the case in Nepal, where there's quite a lot of burning. In fact, this is a slide from one of our earlier reports, but it shows in orange open burning. The dark orange is open burning on a flat ground without protection, and the lighter orange is in a pit or a covered ground. Those are both very common in Nepal and indeed in many low and middle income countries. So it is a form of treatment, but it's not meeting the basic service level requirement for the global indicators. A best practice is not to incinerate at all, but to use other technologies, or if burning, to use a two-chamber industrial incinerator that gets hot enough to prevent the formation of toxic compounds when plastic is burnt. But that's the dark red in the very bottom here, and it's very rare in all of these low and middle income countries. Okay, that's a quick tour of the findings of the JMP 2024 report. Just want to talk a little bit about next steps. First to note that all of these JMP reports, they give statistics and coverage, but they don't talk at all about why things are the way they are, or what actions countries and healthcare facility managers are taking to improve the situation. But WHO and UNICEF do produce a parallel series of reports that do describe those things, starting from the practical steps document that came out in 2019 through updates in 2020 and 2023. And the next in that series is planned for May or June next year. And it's going to focus on the country tracker data, which are collected by WHO and UNICEF. And this is a self-reported assessment that countries make at the national level, not the facility level. And there's a round of data collection underway right now for that. At the same time, the JMP will produce its next report in 2026, but the data from the 2024 report will be available in 2025, and will combine the JMP's recent data with that new data about country actions to produce a report next year, but also to feed into the UN General Assembly in response to the 2023 resolution. So lots happening in 2025, and actually the JMP team has already started looking for new data sources to get ready for the next JMP report, which will be a full one coming out in 2026. So with that, I hope that you all have some questions or some feedback, because we've got a good bit of time for discussion. I'm really interested to hear from the people on this call, how you're working with monitoring Washington healthcare facilities, and if there are any reactions to this report. Maybe over to Ryan to facilitate the Q&A then.
Great, thank you, Rick. If you have a question, feel free to drop it in the chat, or a comment, or any other feedback you might have for Rick. If you're feeling brave, you can raise your hand and I'm happy to call on you. But yeah, the floor is open for questions. I'll start it off with one why folks are kind of thinking. Rick, I'm wondering if as you've been going through all of these various healthcare facility surveys, HMIS data, et cetera, I'm wondering if you've come across other interesting survey questions that perhaps aren't part of the JMP's defined indicator framework that may be of interest to other countries to think about measuring, or might be of interest in sort of future monitoring frameworks like the post SDGs?
Sure, and we do try to give good examples of innovative, interesting monitoring in our full reports. So there were some in our 2022 report, and there will be more in our 2026 report. Off the top of my head, some things that are really important and are often collected are hand hygiene compliance. So, it's one thing to have water and soap available or alcohol-based hand rub, but what's really important is how well those facilities are being used. That's definitely a big one. For the water and sanitation indicators, they're really basic. So there are lots of countries that are collecting water quality or wastewater management. There's a lot of really poorly treated effluent from on-site sanitation in the healthcare facilities that's even more dangerous than untreated sanitation from households because of the conditions that people in healthcare facilities are having. I think there's the basic definitions for the global indicators also don't get into density or coverage at all. I mean, you can have one water point that's available on premises and has water available, and you meet the basic service requirement. But maybe that's not adequate. Maybe it's not providing enough quantity or quality of water to meet all of the needs. Certainly for sanitation, you can meet the basic service level with as few as 2 toilets, one for staff and one for patients and caretakers that has menstrual hygiene facilities and is accessible to people with limited mobility. So clearly that's going to be insufficient for a larger facility. And some facilities do collect data on the number of usable toilets, the number of sex separated or gender neutral toilets that I think is really important. But so far the number of countries that have that type of information isn't really high enough that we can start making aggregates even at the regional level. But we will do that once enough countries have those types of indicators.
Maybe another follow-up question I have is, do you have, it seems like the future of getting more and better monitoring data maybe through HMIS. I know that they can be, there's trade-offs between using something like a SPA or an HHFA versus the HMIS data. Do you have examples of successful, say, advocacy efforts to get countries to adopt these indicators into their HMIS, and what does that process look like?
Yeah, there are definitely some early adopter champion countries. In our 2022 report, we gave an example of data from the Ghana District Health Information Management System, which included the core questions early on, maybe from 2019 or so on. And then when COVID hit, they had at their fingertips, a comprehensive database that said which healthcare facilities had water, which had hand hygiene facilities or not. And they were able to use that to react really quickly and, build up short-term hand hygiene facilities in health centers that didn't have them already. So that's one of our nice examples. One thing I can't speak to how that came to be, but I do know that both UNICEF and WHO have active programs in Ghana, and they're linked closely with Ministry of Health, and also the Ministry of Health has some real champions there. So I assume that they all, got together and made it happen, but I don't know what the drivers were. One thing I would caution against, though, with HMIS systems is they're often trying to reduce the number of items that are included in data collection forms, so they'll combine them. They'll say, a basic sanitation services means blah, 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 blah. They'll list 7 things. And then they'll say, do you have a basic sanitation or not? And the facility will say yes or no. If they say no, you don't know, like, do they have a toilet at all? Or do they have a toilet that's got everything, but it's not accessible to people with limited mobility? You can't unpack if the HMAS uses these aggregate indicators. And I also think there's a pretty high risk that the people filling in the form won't have really absorbed all of those key definitions and what exactly is implied with the basic service level. So I encourage countries to use that longer list. The core questions do have 16 items to map to the full indicator, the full ladders.
Awesome, thanks. Any questions? Anyone brave that wants to unmute and ask Rick a question? Otherwise, I have dozens. I can nerd out all day on monitoring data. This is my favorite topic.
Hey, Ryan, I do see there's one in the chat about improved and not available water. And I think the question is, when water is improved, does that mean it's not reaching a required minimum standard? And this gets back to that point that the basic service level is quite low, and it doesn't specify quantities or continuity or 24/7 or numbers of data points. It is just about having an improved water supply that's located on premises, and the water available part that's really oriented more towards facility assessment. You know, if you have an independent team that comes around, they spend a couple hours at the healthcare facility, they can go to that water point and just see if water actually comes out when they turn the tap, or you know, when they pump the hand pump. And you know, intermittent supply is very common in a lot of healthcare facilities. So it might be that the healthcare facility only gets water for a few hours a day, and when the assessment team comes, water is not available. So that wouldn't meet the basic service level.
Mhm. I see Christine has her hand, and then I know Ron. Yeah, I saw you unmute. So Christine and then Ron.
Sure. Thanks, Rick. This is really great to hear your update. And I didn't realize that you had the interactive dashboard, so that's going to be fun to play with. Could you please talk more about the water quality data that you have and what it looks like? Because I think a lot of times we focus on water availability and supply, but less on quality. So I'm happy to hear you saying that you do have some water quality data now. Thank you.
Yes, and honestly, I know that we had a couple of examples in the 2022 report, but I don't recall the details at my fingertips. But I can say that one thing that's complicated with water quality data is, if you want to know, you know, well, what's the water quality situation in this healthcare facility, then you have to decide where you're going to take samples and how many samples you're going to take. And if you're going to have repeat visits, or if you're going to do it at one point in time. And those will give you very different results. And honestly, it's not clear what the correct indicator to come out of that all is. You know, how many different locations in a healthcare facility should you sample? All of them? I mean, in a large facility, there will be hundreds of water points. You don't need to sample them all. You know, which ones do you sample? And I would say that we honestly haven't gotten a standard methodology to guide sampling in institutional settings, not just healthcare facilities, but even schools or office buildings. So I'm afraid we don't. Again, I don't have the results at my fingertips from the last one, but just to say it's complicated, and we have had some success in adding water quality testing to household surveys, but in a way that's simpler because, you know, there's one place that we do the testing. Even if a household might use multiple sources of water, we say, you know, can I have a cup of water that you would drink today? And then, you know, where did that water come from? It's relatively simple. I'm sorry, I'm not giving you a full response, I'm afraid.
Well, that's okay. I think it shows that this is an area where we could do some more work in the future. So thanks for explaining that.
And maybe one follow-up is that I mean, the principal microbiological parameter we look for is fecal contamination, and E. coli is a preferred indicator. But especially in buildings, in large buildings, in healthcare settings, Legionella is really important. And maybe this is more of the upper middle or high income countries that are focusing concerns on this, but there's a lot of effort being put into to monitor Legionella within buildings and to take corrective measures.
Christine,
Thank
I'll our previous webinar, don't know if you were able to join. Dr. Leanne Ong from University of Oxford presented on some really in-depth water quality work she did in some hospitals in Bangladesh. I'll make sure that you get a copy of that if you didn't get to see it. Really fascinating work, really great insights into thinking through what water quality monitoring might look like in the future.
Yeah, that's Ryan.
Ron, you have a question?
Yeah, great presentation, Rick. Really appreciate it. You mentioned some of the issues with the HMIS data and being able to use that. But I know, I mean, we really want to have HMIS data to inform this, maybe not to provide all of the information, but certainly we want that to inform that. So what do you see as alternatives to saying, well, with HMIS, you have to include all of these questions? I mean, is there a way that we can make it simple enough that it's implemented, but yet give us enough information, keeping in mind the limitations of, the folks filling this out are not WASH people?
Right.
How can we address that? Because to me, that seems like that's really critical that we get that information to help to inform while we're doing more in-depth studies as well. What's your thoughts on that? Appreciate that.
It's a great question. And there's a couple of approaches. I mean, first of all, I think you can think about periodicity, and often an HMIS will be completed quarterly or even monthly, or in some cases even weekly. You don't need to respond about the water source in a healthcare facility with that kind of frequency. So you might be able to have some modules that only go out once a year, for instance, and reduce the reporting burden in that way. And in fact, there might be other modalities that are administrative but not routine HMIS, like certification systems, accreditation systems. If a facility has to undergo a regular accreditation and re-accreditation process, and if having basic WASH infrastructure, at least, in place is part of that accreditation, then that reduces right there a lot of the data collection. Another point I wanted to make on HMIS is that the good thing about HMIS can be that it gives you really granular information at the healthcare facility level that planners need to allocate resources and make policies. But it can also, one challenge with HMIS data, if you're trying to get a national picture, is especially in emerging systems, there can be a lot of incomplete data. So what do you do with the non-response data? It's probably a bad assumption to assume that they're similar to the healthcare facilities that are responding, but it's a limitation if your aim is national statistics. Maybe it's not so bad if your aim is really to identify changes to be made at the facility level, because you can concentrate on the reporting facilities there. But I think the ideal would be to have facilities themselves generating the bulk of data through routine reporting, but having some ground truthing and checkup, spot checks, probably from the Minister of Health or someone else in kind of an oversight function, because there's also the risk that that the people filling out the HMIS forms either just don't fill it in accurately because it's a burden and they can't be bothered, or they have some advantage that they're seeking to get either by saying that things are really good or that they're really bad. So some kind of, oversight, truth checking would be good.
That sounds great. Thank you.
All right, so we had 2 more questions come in the chat. One person said, great to hear about the improvements. I'm curious to know if the environmental surface cleaning efforts also include toilet hygiene and cleaning.
Yeah, thanks Thanks, Nuhu. And again, this is a case of something that would go beyond the basic service level. And globally, we're not even attempting to define standard beyond basic indicators. There are certainly countries that do collect data on cleanliness of toilets or frequency of cleaning. I think there's some really promising approaches more at the facility scale to have like rosters and log books in toilets. So, when was it last cleaned? Those kinds of things are easy to implement and can help track safety and cleanliness at the facility level. But we haven't found good national data sets that include those to highlight in our reports yet, but we would be happy to. So if anyone knows about any, they should send them through.
Great, thanks. And then we have another question from Francisco. What are the types of sources you used from the roughly 600 sources mentioned? How do you vet the validity? And in general, what makes a source reliable for inclusion in the JMP estimates?
Right. So we exercise very little oversight, but we do have a couple of rules about representativeness. So we will use data sources if they're representative of certain areas. So national populations, there are often regional surveys that only cover 4 districts. We wouldn't use those. But if they cover enough of the country to represent at least, I think our threshold is 80% of the healthcare facilities in that country, or the population in that country, if we don't have a subnational distribution of facilities at hand, then we would consider that nationally representative. And the same applies for the rural domain or the hospitals or whatever domain we're looking at. For very small countries, of course, there might only be 1 or a handful of facilities. So in larger countries, we look to have at least 50 facilities assessed to use data in a particular domain. But in like a small island state, for instance, there might only be 7. So then we look to have assessment from at least 30% of the number of total facilities. So we have that kind of quantitative, is it representative assessment. But in terms of the quality and like how well were data collected, there we really rely on countries themselves. Every time we do an update, we share the draft estimates with countries for their review and validation and ask, 1, are we missing anything? But 2, have we included anything that we shouldn't have? So sometimes we'll find like a journal publication that seems to be nationally representative and they measured something in 300 facilities, so it meets our number. But if the national authorities say, hey, we don't trust that, or we weren't involved, then we don't use it. That's fine. But we wouldn't really look at a survey and say, we think that's not reliable, so we're not going to use it. And that's why we use linear regression. We'll usually put in all data points. There are cases where something is a clear outlier, and we'll put that in the country file, but not use it for estimates. And this applies especially to older data sources. Like if you're in a country where you have an early data point that has a very poor proxy of a global indicator, and then later you get a better data point for it, probably that earlier point is less reliable and isn't really comparable to the newer point. So we'll often turn off those older points that are less comparable and not use them in regressions. But again, we share that in the country consultation. And if a country would say, no, you have to turn back on that 2012 point, then we'll do that.
Great, thanks. We have another question. Does the hospital category signify inpatient bed availability?
It does not. We don't have a global definition of hospital. It's true that there's a big overlap between hospital and inpatient or facilities offering inpatient care, but there are some kinds of smaller facilities that might have inpatient care. Is one issue. And another issue is that very often the data sets we have don't include that kind of information. So we're not able to classify facilities on the basis of inpatient, outpatient care in all cases. Some cases, yes, we could. So actually, we basically use the name of the facility, and if it has the word hospital in it, or there are some other large things like a research facility or polyclinics are you know, facilities that do have multiple wards, offer lots of different services. We'll classify them as hospitals, but that's where we would seek clarification from the country to say, well, an Upazila Health Complex, should we count that as a hospital, or is that a smaller facility? And then we follow their guidance.
All right. We've got one last question from Tuseko. Thinking towards the 2026 JMP report, what can be done to facilitate deep dives of countries with data on all letters to understand their processes and how they collect and manage data for the benefit of countries with data gaps?
Well, I invite everyone in this community to like dig into the country files that we have, so you can see exactly which data sources were used, and there often the microdata are available, whether it's from global programs like the SPA that USAID supports, or a lot of national facility assessments. You can get the raw data. You can do some really interesting research on that. I think the JMP team doesn't have the bandwidth to do that kind of deep dive, but we'd be happy to work with people who are interested in that and you know, share what we have. But I think you really would want to be working at the country level to find out, you know, who are the stakeholders, what actions are taking, what are the policies, what are the plans, and how they relate to the service coverage statistics that appear in our reports.
Great. Thank you, Rick. Thank you so much for joining and presenting. This is really fascinating, and thanks for leaving lots of time for Q&A. Great questions from everyone. I hope everyone has a great holiday and New Year, and we look forward to seeing you back in January. We've got another great lineup set up just in the early New Year, so please stay tuned for those invitations. And as Darcy posted in the chat, we will have this presentation and the last presentation will be added to our YouTube channel. You can always go, sorry, not our YouTube channel, WHO hosts it. You can see all the previous COP webinars. So thanks everyone, have a great rest of your day.
Thanks so much, Ryan.
Thank you.